we're going to try to do today is go through the scientific evidence to support these kind of treatments. I mean, one of the main ways that integrative treatments are kind of dismissed in the medical world is just to say there's no evidence. So you say there's no evidence, now we don't have to look at it anymore. So we'll spend the next couple of hours looking at the evidence that doesn't exist. Just a little bit of background in terms of how are we doing so far. So this is just looking at the incidence of cancer. And they're looking at 100 years ago, 3% of deaths were from cancer. In 2000, they were up to 24% of deaths were from cancer. And in certain age groups, this was even becoming the #1 cause. And this included children. It wasn't just that we had more old people, and therefore, we had more cancer. This is also children and young people were seeing increases in cancer. This is just another example of looking at breast cancer. Again, 1940, 50 per 100,000, and in 2000, almost 3 times that amount. And then when they just looked at the year to year, they're seeing cancer in women increasing by 1.6% per year, cancer in men increasing by 1.5% per year. This was a study that went up to 1994, but it's really continuing the same. This was just kind of an interesting one, looking at breast cancer in Chinese women. So when they looked at Chinese women living in China, their incidence was somewhere 40 to 60 per 100,000. When the Chinese women moved to San Francisco, again, it pretty much tripled. And it came up to the population of the Americans. So this is just one thing looking at in terms of what's the influence on the cancer increases. In this case, we're seeing it's not genetic. The women's genes didn't change on the way over from China, but their environment changed. And that, again, had a dramatic effect on their cancer incidence. This was, it's an older paper, but it was an interesting one. This one wasn't done by oncologists. It was done by a statistician. And he was a very, sort of basic kind of thinker. He wasn't looking at what are the tumor responses, do we get partial remissions. He wasn't looking at any of those numbers. It was just, are they dead or alive? So how many are dying from cancer? And again, when he looked at a period of over 30 years, he said that there was continual increases in both the incidence and mortality of cancer. And then in 1997, he did another follow-up paper, again, basically showing the same trend. So here again, they're just saying that, in spite of the, if you want, the advances that they're talking about in cancer treatment, he's not seeing it showing up in any reduction in death rates, from cancer. In fact, again, they're continuing to climb. Interestingly, they only found a couple of cancers where they did see a decrease, and those were cancer of the cervix and colon. Now, what's interesting about these 2 cancers is that these are 2 cancers that they're not getting early detection. It's not like they're catching a cancer when it's small and therefore they're curing it more, which is the theory for early detection. These are the 2 cancers where you can find them before they become cancer. So they find precancerous lesions. So if they catch it before it's cancer, you can actually save lives. It seems that once it becomes a full cancer, even catching it small doesn't seem to make too much difference in the survival. This was another, I guess, controversial paper. It was done by some oncologists in I think it was in Australia. And they did a review of clinical trials reporting 5-year survival attributed to chemotherapy. And they looked at 22 adult malignancies, both in US and Australia. And this is a quote from their conclusion. Their conclusion is the overall contribution of curative and adjuvant cytotoxic chemotherapy to 5-year survival in adults was estimated to be 2.3% in Australia and 2.1% in the So they're saying since the introduction of chemotherapy, how effective it has it been in increasing the 5-year survival? And they're saying pretty small. And their conclusion is it's clear that cytotoxic chemotherapy only makes a minor contribution to cancer survival. I mean, probably what we're seeing with improved survival is not in the 5-year survival. Again, a lot of the treatments are getting, if you want, relatively small increases. So maybe someone that was surviving a year with cancer is surviving 15 months. So they're seeing some marginal benefits, but again, to actually change the 5-year survival, pretty small. And even most of that, 2.3, 2.1% is mostly attributed to a few specific cancers. Again, in the major cancers, they're not really seeing much difference. I mean, this was a paper that, of course, in the oncology world was very attacked because it didn't look very nice. But they really couldn't argue with the numbers. So what we're looking at, again, is their status right now in cancer treatment is that, again, the death rates are going up, and we're not doing a fantastic job of managing it. So we need something more. These are just some statistics looking at some connections of vitamins to cancer. So this one, looking at a large group, 385,000 people in Europe, and here they found just having high levels of B6, folate, or methionine was able to reduce lung cancer by 50%. And if all three of them were good, then it was even better reduction. So this is like, some fairly small changes can have a major impact. Okay, now this was a well advertised study when it came out. And this is the kind of thing that every 2 or 3 years we see another study similar to this coming out. So what did this one say? It says dietary supplements and mortality rate in older women. So this was a study that said that multivitamins were increasing the deaths in older women. Like I said, this was, released all over the world, all the major newspapers, media, everybody was covering this story, and everyone was stopping all of their vitamins because the study said they're going to kill you. What did the actual study say? So this was the conclusion, but what did the actual numbers say? It said that the people taking B-complex vitamins was associated with a 7% decrease in mortality. If they were taking vitamin C, it had a 4% decrease in mortality. If they were taking vitamin D, it was connected to an 8% decrease. So we had all these vitamins decreasing mortality, and somehow we got this conclusion that multivitamins were going to kill you. So how does this happen? Now, fortunately, just after this study, there was another study done in Europe. And this helped to explain things a little bit better. So this was, again, a large study. Almost 24,000 participants. They followed them for 11 years. And what they found here is that baseline users of antioxidant supplements had a significantly reduced risk of cancer mortality, almost half. So when the people who at the beginning of the study were taking antioxidant nutrients, they almost cut their cancer deaths in half. And all-cause mortality from other causes was 42% less compared to people who never took the antioxidant supplements. But in this one, they actually broke down the numbers more. And they said there was a group that they called the non-users at baseline who started supplements during the follow-up period. Okay, so these are people at the beginning of the study, they weren't taking the vitamins. And somewhere along the line, they started. And in that group, they said there was an increased risk of cancer and all-cause mortality. And their explanation for it is they were calling it the sick user effect, which means that why did these people start taking their vitamins in the middle of the study? It's because they became sick. They were diagnosed with some serious illness, and as part of their management, they started taking vitamins. So it wasn't the vitamins causing them to die, it was their illness was causing them to take the vitamins. But when you're just looking at statistical associations, it doesn't separate that out, but these people did. And this is likely the same thing that was going on in the previous study that was showing, again, a group that had an increased death rate, who were taking the multivitamins. Again, it was likely the same kind of thing. They were ones who started them because of an illness. This is, I guess, the latest one of these kinds of studies. This one was just published last year. And here, again, the name of the study, long-term one-carbon metabolism-related vitamin B use in relation to lung cancer risk in the vitamins and lifestyle cohort. Okay, so this was a study looking at the use of vitamins and the connection to lung cancer risk. And what they reported is that there was an increased risk in individuals who were taking individual supplements of B12 and B6, but not if the same vitamins were part of a multivitamin. So why would B12 and B6 cause problems when, if again, you took the same things as part of a multivitamin, it didn't seem to have any negative effect? When I went through this paper, they didn't really break things down much at all. So here we didn't have any breakdown of the sick user effect. We didn't know why these people started taking the B12 and B6. Not only that, but most of the time people who start taking B12, it's because they have a B12 deficiency. And most of the time if you have a B12 deficiency, it's because you're not absorbing it. So if these people start taking B12 because of a deficiency and they're taking it orally, they're still going to have a B12 deficiency because they're still not going to absorb it. Again, there were no blood levels that I could find in any of this study, so we don't know. We don't know, were they deficient at the beginning? Were they still deficient after? There was no information about it. But the conclusion that they still put out there was, taking vitamins B12 and B6 is going to increase your risk. I mean, it's a conclusion that you cannot make from their actual study. Now, this one was a randomized control trial. So this one was a double-blind prospective study. This was actually done with male doctors. And they're looking at the effect of a multivitamin on the prevention of cancer. And in this one, they showed that there was a reduction of about 8% in cancer incidence in people taking the daily multivitamin. The multivitamin that they were taking was actually a pretty low dose, kind of minimal RDA level of nutrients. But even with that, they were still showing that there was a reduction in cancer. Of course, when the study came out, there was, some comments came in, well, it's not so great. It's 8%, it's not so much. So they were downplaying actually the effectiveness of it. If they actually had used real doses of the vitamins, I think they would have got a much more dramatic decrease, like they were seeing with the other studies where they were cutting it in half. But in this one, even with a low dose, they were still getting it. And even the criticism, was a little misguided because, this was actually a group of doctors who presumably already had a good lifestyle and they were watching their diet and they tend to be a healthier group. And the usual position is that if you have a good diet, you don't need to take any vitamins because you're going to get everything you need. This was showing that even adding a small amount of nutrients to people who were already on a decent diet still had an effect on the cancer incidence. This was a little different study. This is people with bladder cancer. So these already had cancer. They were treated for their cancer, and then they were given a supplement. And they were given one of two things. One of them, they gave this RDA multivitamin, just again, a low-dose multivitamin, or they added good doses of vitamin A, B6, vitamin C, vitamin E, and zinc. So they added another 5 nutrients in good doses. After 10 months, they were looking at the relapse rate. So the ones who were taking the low-dose multi, 80% of them had relapsed in 10 months. If they took the added higher dosage nutrients, they cut the relapse rate in half at 10 months. This is just a review paper looking at the effect of vitamin D on cancer prevention. And this, they had a number of observational studies. They had one randomized clinical trial. But their conclusion is that the expected effect of raising vitamin D levels to the 40 to 60 level, usually the bottom of the range is 30. So they said getting it to 40 to 60, though, reduced case fatality rate of patients with breast, colorectal, prostate cancer by half. So again, now we're looking at another nutrient that can have a fairly dramatic impact on cancer. How much do you need to get your levels up to that? Again, a lot of the supplements are 400 units, 1,000 units maybe. But in order to get your blood levels into this range, you usually need to take 4,000 to 5,000 units a day. So taking the recommended dose is not going to get you really into these preventive ranges.
Even in Israel with the sun and everything?
Yeah, I've probably checked in this country, I'd say at least 1,000 people for their vitamin D levels. I think I found 4 that made it into the normal range. Everyone else was all deficient. Apparently, they did do some study a number of years ago here in the country where they were looking at vitamin D levels in the population, and they found pretty much the same thing. Almost all groups were below the range. There was only one group that had good levels, Matzilim. So their blood levels were up in like the 60 range. So if you are outside in the sun, without your clothes on most of the day, you can have really good vitamin D levels. But that's not the case for most people. Okay, and this is a breast cancer risk study. Again, looking at the effect of certain nutrients. So here they had a comparison of antioxidant intake 10 years or more. They had, 2,300 cases with breast cancer compared to like almost 2,500 controls. So they looked at the ones with breast cancer, the controls without breast cancer, and what they were taking. So here they showed that breast cancer risk in premenopausal women was reduced by 54% in women taking zinc. In postmenopausal women, you could reduce it 26% with a multivitamin, 42% with beta-carotene, 21% with vitamin C, 25% with vitamin E, and the winner again seemed to be zinc, even in postmenopausal where they had a 53% reduction. This is a treatment study. So this is women with breast cancer. It's a prospective study. So they had women who were they all got the conventional cancer treatments, and a group of them added nutritional supplements starting in the first 6 months after diagnosis. So they started the supplements pretty early in their treatment. So they found that women who were taking vitamin E, vitamin C, or multivitamins reduced their risk of death by 18% and the risk of recurrence by 22%. So again, this is taking your supplements with your conventional treatment and reducing your chance of dying. Similar one here, women diagnosed with early breast cancer. And again, here the women who were taking multivitamins and minerals before they were even diagnosed, they were already on vitamins before their diagnosis and continued on them during their treatment, were 31% less likely to have a recurrence and 47% less likely to die of their breast cancer. And interestingly, 27% less likely to die of any other cause. Now, if the women were taking only vitamins and not minerals, we didn't see the same benefit. And that would go along with the other one showing how important things like zinc were in reducing the risk. So you can't just take a B complex, you need to really be taking the whole mineral complex with it. This is a paper that also is sort of stirring up a little more controversy. One of the popular things that's done now in breast cancer treatment is to do what they call neoadjuvant chemotherapy. So before they do the surgery, they give you chemotherapy. The idea being is that this way we can make the tumor smaller and then we can do less of a surgery. So this is a fairly common practice right now. One of the problems, though, is that they were looking at the actual tumors when they gave this neoadjuvant chemotherapy. And what they found is that the breast cancers that were remaining after the chemotherapy, because they didn't disappear, they just, if we're lucky, got smaller. They were looking at specifically with paclitaxel, doxorubicin, plus cyclophosphamide. These are the common drugs that are used. They showed an increase in what they call tumor microenvironment of metastasis. So this is something that's an indicator of the likelihood of the cancer metastasizing or spreading. And they found that when they gave these chemotherapy drugs, they increased the score, which means that the chemotherapy, and this was their quote from the paper, that despite decreasing tumor size may increase the risk of metastasis. So it might have looked better on the picture, but it might have actually been more dangerous. There was some similar work done, again, it was along the same lines of this, where they were looking at cancer stem cells. And they found that in tumors, something like 2 or 3% of the tumor was in the form of what they call cancer stem cells. The cancer stem cells are those cells that are the dangerous ones. Those are the ones that can spread in the body, set up new tumors, cause recurrence. The ones that are not usually killed, by chemotherapy too. But when they looked at using the chemotherapy before, and then they took out the tumor, they found that the 2 to 3% of stem cells increased fairly substantially. And this kind of goes along with this study, saying that we made the tumor smaller, but we increased the danger. This is another controversial area that I just want to touch on a bit. This is the idea of hormones and breast cancer. Now, most of this really got stirred up back in 2001 when they did the Women's Health Initiative. And here they were looking at their conventional hormone replacement therapy, which was Premin and Provera, the horse estrogens and synthetic progestins. That was the standard HRT. And they said the women taking this compared to the placebo had an increased risk of breast cancer by 26%. And they also had increased blood clots, strokes, cardiovascular disease. So these hormones were not looking so good. In fact, once this study came out, it was probably millions of women around the world stopped their hormones, based on this study. What was not so widely disseminated is this is actually a comment from the paper itself, where it says, it remains possible that transdermal estradiol with progesterone, which more closely mimics the normal physiology and metabolism of endogenous sex hormones, may provide a different risk-benefit profile. Meaning that if they had used different kinds of hormones, maybe they would have got a different result. But what went out to the world was hormones, blanket, description, all hormones are bad and you can't take anything. But I said, even at this point, when they first published it, they're already saying that, maybe we have some information that they're not all the same. They published another paper 10 years later from the same study. In this one, there was a group of women. The reason for giving the Provera was just if you had a uterus, because if you gave the high doses of estrogen by themselves, you can stimulate endometrial cancer. So they gave the Provera to prevent that from happening. So they said, well, if you don't have a uterus, we don't have to give it. There's nothing to protect there. So there's a group of women who were only on the estrogens, not on the Provera. And what they found in that group, that there was a 20 to 27% reduction in breast cancer. So when they took out the synthetic progestins, they didn't have any more increase in breast cancer. In fact, they were looking at it, maybe even reducing it. So estrogen, what was thought to be the big culprit, didn't look like it was when they did this follow-up. This is another, these were two studies. Again, this was another really controversial thing. They said, because can women take hormones after they had breast cancer? In general, it's forbidden. If you, any of them college say you had breast cancer, you cannot take hormones. Prior to these studies, there was actually 8 clinical trials of women who took hormones after breast cancer. None of them showed any increased recurrence. But they weren't randomized, controlled, double-blind trials, so they weren't given so much importance. Then in Sweden, they did 2, randomized, double-blind clinical trials of giving hormone replacement after women having breast cancer. So this one, they finally thought, okay, now we're going to have the answer. Is it really a problem or not? Because we have 2 trials now. And they were both done in the same place. They were both done in Sweden with a similar population. But again, there were 2 separate trials that were being done at the same time. So what was the answer? So the big answer that we got, is it okay or not okay? One of the clinical trials showed an increase in breast cancer recurrence, and the other one showed no increase and maybe a slight decrease. So we got opposite results from 2 clinical trials in the same place with the same population. So why? Why do they get opposite results? Well, they weren't exactly the same. The design of the clinical trials weren't exactly the same. In the Stockholm trial, the one that showed the possible decrease in recurrence, they minimized, by the way, when they gave hormone replacement, it was the same one that they used in the Women's Health Initiative. They gave Premin and Provera. So they were using the same stuff. But in the Stockholm trial, they minimized the amount of the progestin. And they only gave it 14 days out of every 3 months instead of giving it continuously, which was the other way that it was done. And so we see here again, like the other one, as soon as this one they didn't even eliminate the Provera, they just minimized the exposure, and just doing that prevented any increased recurrence rates. This one was also this was an animal study, but it was very revealing. So this one, they took breast cancer, they implanted in the mice, and then they test things on it. This is the way often a lot of new treatments are tested initially. So you test them in the mouse model. So here they were using aromatase inhibitors, which is a standard treatment for breast cancer. It's to get rid of the estrogen. So that's one of the standard ones. But then they also tested a number of hormones. And they used different combinations. They had actually 8 different groups that they were testing. And they were using combinations of the aromatase inhibitor, estradiol, progesterone, and testosterone. Here they were not using Premin and Provera. They were actually using the natural hormones that are produced in the body. And they got some really interesting results when they tested this. They said if they gave a placebo or low doses of estradiol and progesterone, that had the fastest growth of the cancer. So if they gave nothing, it grew. And if they gave a little bit of hormone, it seemed to grow just as fast. Then they gave the aromatase inhibitor to block the hormones, and it reduced the growth of the cancer a certain amount. Then they gave a higher dose, estradiol and progesterone, by itself, and it reduced the growth exactly the same amount. So giving the hormones reduced the growth just as much as blocking the hormones. And then they did one more where they gave, actually a couple more groups. This one they actually gave the aromatase inhibitor with the estradiol and progesterone, and that had exactly the same curve. It reduced it the same amount as giving either by itself. But then they gave estradiol, progesterone, and testosterone, the 3 hormones together. That had the most dramatic reduction in the growth of the breast cancer. So replacing or giving the natural forms of the hormones in decent doses actually had the greatest effect on not stimulating the cancer, but reducing the growth of it. Also interesting, when they use aromatase inhibitors, when they did it in the mouse model, it's similar to what we see in people, that you give it and it can slow the growth a certain amount while you're taking it. Eventually it stops working because the cancer cells change. And then when you stop it, they find the cancer starts growing much faster after. So it becomes more aggressive after they finish the treatment. It's also interesting with this study because they didn't even just look at the effect on the cancer. They were looking at more physiological effects. Because aromatase inhibitors, when you block the estrogens, there's a lot of side effects, including things like osteoporosis, memory issues. It's affecting a lot of tissues in the body. And they found the same thing here. When they did it with the mouse model, they found that the mice were not very happy when they got rid of the hormones. And if you want to call it, their lifestyle was much better when they were actually given the hormones. So now this is really putting into question a lot of our assumptions about how breast cancer works and the effects of hormones on it. Another study, again, just looking at some statistics. This one was a randomized controlled trial. And this was looking at the effects of some vitamins on gastric and esophageal cancer. So they said also, again, similar to some of the other ones, that people taking what they called their vitamin treatment in this trial, which was just vitamin C, E, and selenium, but just adding those reduced the deaths from gastric and esophageal cancer by 50%. And then again, we get the studies sort of on the opposite side. So here we have treatment with antioxidants and other nutrients in combination with chemotherapy and radiation in patients with lung cancer. This was also a very well publicized trial. No, sorry, this is a different one. I'm just going to show you the other one. Okay, so this is the one where they gave vitamin E and beta carotene to smokers, and they looked at the effect on lung cancer. So in this one, their conclusion was that giving the vitamin E didn't make any difference, but giving the beta carotene showed an 18% increase in lung cancer. And of course, again, the word that went out was, taking beta carotene is going to cause lung cancer. So how did this happen? We have some other studies, though. This one was a small study, but it was sort of giving the opposite kind of conclusion. So this one, they used antioxidant and nutrients. It was only 18 patients with small cell lung cancer, which is not a disease we get very good results with. But they were given a high-dose multi-nutrient supplement. And when I went to the paper to look at exactly what they give, they were actually giving a broad range of almost everything and in really substantial doses. This wasn't your one-a-day multi. They were giving real doses. The expected survival of this cancer at 30 months is about 1%. Okay, so again, the survival is very poor with this. But they found 40% of them were still alive at 6 years. And if they started the supplements even earlier in their course, it was even better results than that. So this is showing, again, a fairly dramatic response, to a very difficult cancer by adding, substantial doses of nutrients. This is another one, was done later with a different form of lung cancer. Again, not very good prognosis. And they all got, like in the previous one, they all got the standard treatments. And this one, they just added vitamin C, vitamin E, and beta carotene. So it wasn't like the previous one where they gave the wide range of good doses. This one, they just narrowed it down to a few supplements. And the results here is that the survival at 1 year with chemotherapy by itself was about 33%, and it went up to about 39% when they added the nutrients. And again, when you look at these two studies, the thing is when they gave the high doses of a lot of nutrients, they got a fairly large response. When they gave a little bit of a few, they still got a response, but it was much more reduced. These are just a couple of lab studies that just sort of support that whole idea. So in this one, they took rats, and they gave a chemical that produces cancer in 100% of them. So it's a really carcinogenic chemical. But when they did that, they added various combinations of nutrients. So they had selenium, magnesium, vitamin C, vitamin E, and they either used them 1 at a time, 2 at a time, 3 at a time, or 4 at a time. If they used one nutrient, just one nutrient was able to reduce the cancer by 50%. 2 at a time reduced it about 70, 3 about 80, and if they gave all 4 nutrients, they prevented the cancer in most of them. So they're showing that there's synergy, that when you're using a broader spectrum, you're going to get a better result. This was just another laboratory study looking at the effects of vitamin C and K3. And they said each one has been shown to have anti-cancer effects, but if you gave them together, then you could get an effective response at 10 to 50 times lower doses. So the synergism is important. Now going back to this study of, so why, when you take beta-carotene in smokers, did you get an increase? After all this great information of how we're reducing cancer incidence with nutrients, why did we get an increase when they did this study? And here they found that, before they did the study, why did they do this? They found that there were over 200 epidemiological studies showing fruits and vegetables that were high in antioxidants had a lower cancer risk. There were 11 studies just showing beta-carotene protective against lung cancer, but still that other study showed that it made it worse. Now, one of the explanations for it is that, again, that study wasn't done like these epidemiological ones. Here they were showing getting beta-carotene usually as part of your food. But when you're getting it as part of your food, you're getting it together with thousands of other substances. And when they looked at some of the research showing that isolated antioxidants, when you use one antioxidant by itself, how does it work in the body? It neutralizes a free radical, but in the process it becomes a free radical. And sometimes a very aggressive one. And what normally happens in the body is that that free radical gets neutralized by another antioxidant, and it sort of gets passed down the chain until it's eliminated. So these things, again, antioxidants always work in teams. And if you only give one antioxidant by itself, and again, this was in smokers. This is in smokers, which means they had a lot of free radicals around. So you had one wimpy antioxidant trying to deal with a pool of free radicals. And again, often what you're doing, though, is creating some more aggressive free radicals. And that can make the situation worse. So this study was done in a way that you should never do antioxidant studies. Unfortunately, most medical studies, they're usually done by isolating one thing. If you gave 25 different things, then it's always like, well, we don't know what's working. But in these kind of studies, it's important because it's the combination itself that's working, not any of the individuals. This was another one that was doing something similar. So this was a study of head and neck cancer patients. The standard treatment for them was radiation. And then they either had the radiation or they added either beta-carotene or vitamin E. Same kind of thing they did with that lung cancer one. They used beta-carotene and vitamin E. Again, it's relatively low doses too. And the results is that the ones who got the supplements, the antioxidants, had a 40% increased early recurrence, which means the cancer recurred earlier when they gave them, again, a single antioxidant. When they looked farther down the road, it didn't seem to make any difference, but at least they was noticing an early recurrence. So again, the conclusion that came out of this was, don't give antioxidants during your radiation. That was the assumption here. What seemed to be much less known is that this same group, a year later, published another follow-up paper. And here they broke down the statistics further. So in this one, when they looked at it, they said the increased cancer recurrence only occurred in patients smoking during their radiation treatments. If they weren't smoking while they were getting the radiation, and in the antioxidants, made no difference in terms of the recurrence. But they found that even with that little bit of antioxidant, it still improved the side effects of the radiation. There was less tissue damage to healthy tissue. So even with that little bit of antioxidant, there seemed to be some benefit. And again, it only was in the smokers. Again, so people, even with the head and neck cancers, even while they're getting their radiation treatment, they just continued their smoking. So again, they were creating another high free radical environment in their body and throwing another single, antioxidant in the mix. And it was probably making it worse like it did in the lung cancer one. Again, unfortunately, still the main message that went out from this was don't take antioxidants during radiation, instead of don't smoke during your radiation. This is a researcher, Prasad, who was he was doing a lot of work looking at antioxidants, interactions with chemotherapy. Mostly he was doing these in animal models. They're laboratory studies, showing the same thing, that antioxidants, if you give it just a single antioxidant in a low dose, it can make the situation worse. He did another study where they used a combination of vitamin A, vitamin E succinate, vitamin C, and mixed carotenoids, not beta-carotene. He used a mixture of them. So he was using multiple antioxidants together. And when he did that, it reduced the proliferation of melanoma cells in culture by about 50%. Then he continued further. He just increased the amount of vitamin C in the same mixture, so increasing the dose, then dropped down the 90% reduction in proliferation. Yeah?
How come a single antioxidant is making it worse than better?
No, I said largely, it seems that mostly because, again, when you have one by itself without its team, like I said, when that antioxidant gets used and it neutralizes a free radical, it becomes a free radical itself. And if it doesn't have the team to deal with that one, then, and again, sometimes it becomes a very aggressive free radical, even worse than the one it just neutralized. So if you don't have the rest of the team there to pass it on to, now you may have just created a worse environment. Well, there's another interesting thing too, because this researcher, when he was looking at vitamin E, he also found that not all vitamin E was the same. Here we used something called vitamin E succinate, which was more like your natural vitamin E. All the other studies were using something called vitamin E acetate, or alpha-tocopherol acetate, which is a kind of synthetic form of vitamin E. What he found, though, is that vitamin E succinate had an effect against cancer growth. The acetate didn't. But that's the form that was used in all these other studies. So it's not even just using antioxidants in combinations and in doses. Even the forms of them can make a difference. Prasad did another one, just again some more information showing vitamin A and beta-carotene at high doses given before radiation and during the entire observation period produces more than a 90% cure rate in mice with breast cancer transplanted. So here they were combining vitamin A and beta-carotene at high doses and doing radiation. Again, this was very similar to that study with the head and neck cancer, except when they gave high doses in combination with the radiation, they got a 90% cure rate. If they gave the radiation by itself, or even the vitamins by itself, they didn't have much effect at all. So here we're seeing that there's a dramatically increased effect when they added the antioxidants to the radiation treatment, not an inhibitory effect. But again, here who's using good doses of combinations. These are just there's a couple of review papers looking at various studies of combining antioxidants with different kinds of conventional treatment. So here this researcher looked at 280 studies, 50 human clinical trials, and the conclusion is that they enhanced the killing of therapeutic modalities for cancer and decreased their side effects and protect normal tissue. So when they added, again, there was always this position that antioxidants are going to interfere with the chemotherapy. In this review, they could not find that. In fact, most of the time they found the opposite, that it improved the results and protected the healthy tissue. Keith Block, another integrative oncologist, did another review of his own. He was much more restrictive in terms of which papers he included. He only included 19 clinical trials. Same conclusion. There was no trial that showed an interfering effect of antioxidants with the conventional treatment. And again, many studies showing increased survival times, increased tumor responses, or both, as well as less toxicity to the body. So the fear of antioxidants with conventional treatments is not really being supported by the information we have. We have some other individual clinical trials looking at specific nutrients. Here they were looking at glutathione in a oxyplatin-based chemotherapy for colon cancer. A very common side effects of the platin types of chemotherapies is nerve damage, is getting neuropathy. In these patients, they found that the neuropathy occurred in 42% of the group that just got the chemotherapy. If they added the glutathione, they reduced the neuropathy to 27%. Similar thing with vitamin E in patients treated with cisplatin and the effects on the neuropathy. In their study, they found that 85% of the cisplatin group had neuropathy, but only 31% if they added vitamin E. And there were, again, a number of others that showing similar things, that you can reduce neurotoxicity, cardiotoxicity, lung damage, mucositis, bone marrow toxicity. These things they're not going to be eliminated, but they can be reduced by adding antioxidants to it. And again, no trials reporting any decreased efficacy of the chemotherapy. A couple of case reports. These are 2 cases of advanced ovarian cancer. Don't have great prognosis with ovarian cancer either. They had their standard chemotherapy, and they were taking high doses of oral antioxidants, and they were getting intravenous vitamin C twice a week. Both of the patients show no evidence of disease over 3 years later, which is unusual for advanced ovarian cancer. A few other published case reports. This one was looking at 3 cases of cancer treated with intravenous vitamin C and supplements without chemotherapy. So these patients, for whatever reason, they declined chemotherapy. They only did the intravenous vitamin C and oral supplements. And again, these were 3 cases that were showing unexpectedly long survival times with it, and one that looked like it was actually cured. And I mean, these were cases that were published because they were so well documented, in terms of the effect. Another study showing intravenous vitamin C in breast cancer patients. Again, 125 breast cancer patients, all of them had the standard care. But 53 received intravenous vitamin C for at least 4 weeks. And here they showed that the intravenous vitamin C had a significant reduction in the symptoms: nausea, loss of appetite, fatigue, depression, sleep disorders, dizziness, hemorrhage. So all of the common side effects of chemotherapy were significantly reduced by adding the intravenous vitamin C. And then, of course, we get the other side. So this was not a clinical trial. This is a laboratory study. The study is saying vitamin C antagonizes the cytotoxic effects of anti-neoplastic drugs. So here we have one saying vitamin C is going to interfere with chemotherapy. And what they did here, they said they tested what they call dehydroascorbic acid. This is not regular vitamin C. This is oxidized vitamin C. Okay, so this is not what we get in our diets. It's not what we give intravenously. It's actually what we throw away. So if we have giving intravenous vitamin C and we see it's getting oxidized, we don't give that to somebody. But this is what they used. So they were using dehydroxyascorbic acid combined with a few chemotherapy drugs. on leukemia and lymphoma cells, and they said it decreased the cytotoxicity of all the drugs tested. So again, this was a laboratory study saying that dehydroascorbic acid can decrease the effectiveness of certain chemotherapy drugs in the lab. But again, this was not with the vitamin C that actually is used. But again, this is a study that went out to all the oncologists and really, gave them a position of do not take vitamin C when we're doing chemotherapy because it's going to interfere based on this. Fortunately, a few years later in Germany, they did another study, and this one was much more elaborate. So this one they said, well, is there a difference between using real vitamin C and oxidized vitamin C on the effect? So they did something similar. They gave chemotherapy drugs on cancer cultures, and they combined it with ascorbic acid or dehydroascorbic acid. And their conclusion was if they used regular vitamin C, they said even by itself, it had an interfering effect on the cancer. And when they combined it with the chemotherapy drugs, it either had no effect on the chemo or an improved effect of the chemo. So here again, they came to the opposite conclusion, that if you use ascorbic acid, it enhances the cytostatic potency of certain chemotherapy drugs or had no negative effect, either one. So their conclusion is that there's a therapeutic benefit to giving the vitamin C, not a detriment. This was just a meta-analysis where they looked at 10 prospective studies using either vitamin C by supplement or increasing it in your food. So they weren't using very high doses. These were just oral intakes of vitamin C. And they looked at about 17,000 women with breast cancer, and the ones that even just took like sort of modest increases, they showed a 19% decrease with a vitamin C oral supplement. If they got the extra vitamin C from food sources, they had a 27% decrease. Now, again, that would make sense given that if you got it from your fruit sources, you had the vitamin C together with a few thousand other antioxidants working with it. This one was a double-blind clinical trial looking at ovarian cancer, where they gave intravenous vitamin C and oral antioxidants. In this one, they were showing that, again, mostly what they were commenting on was the decreased toxicity of the chemotherapy. So they went through their chemotherapy with much less damage when they added the vitamin C. It looked like there was also an improved survival rate, but I don't think it reached statistical significance that they could put it in the paper. But there was definitely no reduction in efficacy when they did it. This is just a comment on this whole issue of evidence-based medicine. So this was actually something I took from John Hoffer in Canada, who teaches evidence-based medicine at McGill. So he uses this as an example of how evidence-based medicine, the word itself, is now being misused. You may remember this story. This was back in 2010. In New Zealand, there was a farmer with the swine flu. He got severely ill. He was in the hospital in a coma, considered terminal. He didn't have too much longer to survive. The family didn't like that answer, so they started looking around for anything else they could do. They came across intravenous vitamin C that can be helpful in viral infections. So they went to the doctors there and said, can we give him some intravenous vitamin C? The hospital doctor said, we refuse because there's no evidence. maybe it's dangerous, it's unscientific, it's irrational, there's no evidence, so we're not going to give it. The family actually went to court. They got a quick appointment with the judge. The judge said, he's going to die, why not give him the vitamin C? So they gave it to him, and he made a full recovery. Now, again, the comment still from the hospital was, but it had nothing to do with the vitamin C. It just happened to he got better when they gave it to him, but he was going to get better then anyways. Now, with the other thing going on, there's a manual called the Guidelines for the Provision and Assessment of Nutrition Support Therapy in the Adult Critically Ill Patient. This is put out by two groups, the Society of Critical Care Medicine and the American Society for Parenteral and Enteral Nutrition. So what is this? This is a manual of evidence-based treatments in critical care. So what did the manual say? So this is their manual, that they use at the hospital. And this one was from 2009, which was the year before this case. So their manual said that high-dose intravenous antioxidant therapy should be used for all critically ill patients, based on the evidence, because of the weight of the evidence. And they said they should be giving, at least 1 gram every 8 hours of vitamin C intravenously to critically ill patients because it improves clinical outcomes, based on the evidence. But again, in the hospital, it was dismissed just by saying there's no evidence, therefore we don't have to look at it. By the way, I don't know if you know that, I think it was about a year ago or so, they did another clinical trial in the United States, this time with septic shock. So septic shock is an infection that you pick up in the hospital that has a really high mortality rate, and there is no treatment. The antibiotics don't work. There really is no treatment for it, and a lot of them die. So a hospital in the States decided they're going to give intravenous vitamin C and a couple of other nutrients to these people with septic shock. And they did, and they dramatically reduced the death rate just by adding intravenous vitamin C to something that there was no other treatment for, and a lot of people, thousands of people dying every year from it. What was the response? Response, well, we can't use this. There's not enough evidence yet. Even though there was no downside and it was saving lives, we have to do more studies before we can agree to use it. The hospital who did the study said, we don't need more evidence, we're going to use it. Now, the same one who showed that thing with the evidence-based medicine, he actually did a study in Montreal, and this was using intravenous vitamin C combined with chemotherapy in patients with advanced cancer. So what was this? It wasn't a large clinical trial, but these were cancer patients after they had been treated. And they were at this point considered terminal, multi-drug resistant. There was nothing else that could be done for them. And there was no point in doing any more chemo based on their condition. So they took these patients and they gave them intravenous vitamin C along with a chemotherapy that would work if it wasn't resistant already. So these again were terminal patients. These were the hopeless cases. But still, even with that group, they said half of the patients didn't show any benefit, but half experienced either transient stable disease or longer lasting stable disease. So these were ones that at least they prolonged their life by adding the intravenous vitamin C. And again, in the study, they showed no downside. There was no toxicity to giving it. A quote from the paper itself, this is some of their conclusions. It's showing a bit of the frustration of the researchers. They're saying the present state of chemotherapy is unsatisfactory. New cancer drugs continue to be developed and approved on the basis of marginal improvements in survival at an unsustainably high financial cost. It would seem more rational for cancer investigations to attempt to improve the effectiveness of well-known inexpensive cancer chemotherapy by studying their clinical interaction with antioxidants, especially vitamin C. And they said, despite its biological and clinical plausibility, it's ignored by conventional cancer investigators and funding agencies. She said, we have evidence, but no one's interested. This was actually done by the same group in Montreal. Just an interesting one, saying that people being admitted to the hospital for any kind of reason, they said 60% of them, when they were coming into the hospital, were deficient in vitamin C. And then after being in the hospital for at least 17 days, it was no better. So the hospital food didn't seem to improve their vitamin C status. But it's saying that, vitamin C maybe is not just important because of the therapeutic effect, it can even be important for treating the deficiency of people coming in. Okay, now we're just going to change directions a little bit now. Looking at some of the theories of cancer, what cancer is. So here we have in papers, this is back in 1986 in the New England Journal. It's titled Tumors, Wounds That Do Not Heal, Similarities Between Tumor Stroma Generation and Wound Healing. So it's interesting, they found that the cancer behavior looks a lot like a wound that's trying to heal. So it's creating some of the same processes. The cancer is creating inflammation, growth factors, enzymes, angiogenic chemicals. So it's producing some of the same things that you would need to heal it. Except with a normal wound, it heals it, and then it turns off all of these things. They found in cancer, it's just kind of like on autopilot. It just keeps going and going. So all of these processes that would normally heal a wound are going to be used as, these are connected to what are being called oncogenes. These are the things that are promoting the cancer growth. And there's a lot of things that influence cancer promotion. Oxidation from free radicals, inflammation, immune system failure, high blood sugar and insulin resistance, and even just high levels of stress. Stress hormones themselves will also suppress the immune system, increase inflammation. So all of these things, though, are going to help promote the growth of cancer. So that's obvious. So here we have a summary slide looking at mechanisms of natural substances against cancer. And we have a number of different things, looking at the effect on the gene products, on the gene expression itself. So we have a fair bit of information looking at how a lot of natural substances can affect the function of the cancer cells. Some of the ones that are here are things like EGCG, which is a green tea extract. We have extracts, genistein, which is a soy extract, curcumin, resveratrol, which comes from grape skins, omega-3 fatty acids. So we have a whole range of different natural substances with identified anti-cancer mechanisms. Which is also important about this slide is that you'll see any of the individual substances show up in multiple places here. So that the natural substance have multiple targets in the cancer cells. And not only that, but we see multiple different substances affecting the same target. So if you use a number of things together, you're going to get synergism on particular targets, and you're going to cover a wide range of different ones. A lot of, let me just, yeah. Okay, so, but the conclusion here is that, what we have, again, naturally occurring are these targeted therapies. So a lot of the research being done now in the cancer world is looking for targeted therapies to go after one particular mutation or function in a cancer cell, one at a time. And they said, here we have these substances that can go after multiple targets and synergistically act with others to hopefully even get stronger effects. Okay, what I'm going to go through is now is cancer mechanisms and how we use these things in treatment. This is just another list of what they call pro-cancer events, things that are involved in the promotion and growth of cancer. So these are some of the identified things. One is genetic instability. So they find that the mutations occur easily because the genes themselves are not stable. You have abnormal expression of genes. We have abnormal signal transduction, abnormal cell-to-cell communication, induction of angiogenesis, of new blood vessel growth, invasion of metastases, and immune evasions. So these are considered some of the features of cancer. And when we're looking at treating it, we want to try to treat all of these different areas. We want to look at the genetic instability, which is largely coming from the oxidative stress from the free radicals. We want to affect the abnormal gene expression, these oncogenes, these cancer genes that are activated that can be turned on and off. We want to see if we can affect those. Signal transduction to the cancer cells receive signals to increase proliferation. Encourage cell-to-cell communication. Cells also talk to each other, and they get information from neighboring cells that affect their own growth. Cancer cells in general turn that off. So the messages may be coming from their surroundings saying, okay, enough, you can stop now. That doesn't get through. So maybe there's ways we can increase the message getting through. To reduce angiogenesis, the chemicals that the cancer is using to stimulate its own blood supply. Invasion of metastases, how do the cancers spread in the body? They don't just spread, they use mechanisms. There's enzymes, there's factors that they use to do that. And the immune response. Cancer also, one of the ways it survives is that it has ways to hide from the immune system, so it's not eliminated as a normal defective cell would be. Now I want to get to the whole theory of cancer. The standard theory right now is that cancer is mutations. Okay, cancer forms because you have some mutation, another one. After a series of mutations, you develop the cancer. Okay, this is the accepted theory. There was a project started back in 2006 where they were looking at mapping out all of the genes in a wide range of cancer cells. And the excitement at the time was, we're going to get this and we're going to get a map. And we're going to see which mutations are connected to which cancer. We're going to design our drugs to go after these mutations. And that's going to be the end of cancer. We're done with it. Once we do this project, we're going to have the answers. So what was the conclusion? So in 2015 in Nature, they published a review of this. And one of the conclusions is that most of the mutations formed a bewildering hodgepodge of genetic oddities with little commonality between tumors. And that cancers are often quick to become resistant, typically activating different genes to bypass whatever cellular process is blocked by the treatment. Okay, so what they're saying here is they couldn't find any pattern. They couldn't find any mutations that are consistently connected to a particular cancer. They were kind of all over the place. Maybe even worse for the theory is they had cancer cells, they were cancer, that seemed to have none of the mutations that were thought to be necessary to be cancer, but they were still cancer. And then when it came to treatment, again, even when they did find some particular mutations and they designed something to act on that, it seems to only be a temporary effect. And then the cancer just sort of activates some other pathway, bypasses whatever you're disrupting. So it's been disappointing. By the way, one of the people involved in leading that project was James Watson, of Watson and Crick, the discoverer of the DNA structure. So he was still alive, he was still working for the National Cancer Institute, and he was one of the people involved in running the project. At the end of the project, he actually made a comment that's saying, I think we're going in the wrong direction. I mean, this is the gene guy who's saying that going after the gene mutations, this is not the direction. So we started looking at an old theory. So back in the late 20s, early 30s, there was a researcher in Germany named Otto Warburg. He was considered maybe the leading cancer researcher of the time. And he was a brilliant guy. And he was doing some work there where he was looking at cancer cells. And he made a statement. He said he found there was one thing that was the same. Didn't matter where the cancer cell came from, there was one thing that seemed to be common, which was their metabolism, what they call their respiration. What he was finding is that normal cells will take some glucose, combine it with oxygen, and make lots of energy. That was the normal mechanism. So the cancer wasn't doing that. He said they were taking glucose and fermenting it, meaning they were doing it without oxygen, primarily, which is not a very good process. I mean, in terms of energy production. You don't get so much energy from glycolysis, from fermentation. But he said that's what they were doing. Even if there was lots of oxygen around, they weren't using it. And this has become a known feature in cancer. I mean, almost most oncologists know about the Warburg effect. So it was named after them that cancer cells seem to do this. They have this shift in metabolism. Warburg took the position that it wasn't just a sign of a cancerous change, it actually was. This was the foundation of the change. A lot of work has been continued with this in more recent years, especially after the whole mutation theory seemed to be falling apart. So there was a lot more focus going back to this. One of the guys doing a lot of work with this was Thomas Seyfried. So 2010, he already published a paper saying emerging evidence indicates that impaired cellular metabolism is the defining characteristic of nearly all cancers, regardless of cell origin. The general hypothesis that genomic instability and essentially all hallmarks of cancer, including aerobic glycolysis, the Warburg effect, can be linked to impaired mitochondrial function and energy metabolism. So now they're looking at what sets off the cancer seems to be damage to the normal respiration which takes place in the mitochondria. These were a couple of other interesting studies that were looking at things from a similar but different angle. This also took place in the late 80s when we had technology now where we can do things they couldn't do back then. So here they were able to rearrange cells. So what they did first was they took the nucleus of a cancer cell, presumably containing all the cancer genes, all the mutations, but they put it into the cytoplasm of a normal cell. And most of the time it did what they called extinguish the tumorigenic phenotype, which means it behaved like a normal cell, not like a cancer cell. It had all the mutations, all the cancer genes. This was just at a different university. They did a repeat experiment. They did try to make it even more tightly controlled, but the same conclusion. Then they did the opposite. They took a normal nucleus, no damage, no mutations, and they put that into the cytoplasm of a cancer cell. And most often it behaved as a cancer cell. So it did seem that what was going on in the nucleus had very little effect on the behavior, whether it was going to be cancer or not. And then they were coming back to, well, what was doing it? And it seemed like the main sort of culprit in it was the damaged mitochondria. And then they did some work looking at what they call retrograde regulation due to mitochondrial dysfunction. So here they're looking at when you damage mitochondria, they actually send signals to the nucleus, to the genes, and they turn on genes. Likely what they're doing is trying to turn on repair genes, like we saw with the cancer as being a wound. So now there's damage to the cell. It's sending messages to see if we can start getting things fixed. But it's turning on the same genes that are going to be called oncogenes, cancer genes. And these are the ones that will affect, again, the behavior, the metabolism, the proliferation, tumor metastases, all the features of cancer. This was just kind of an interesting paper looking at the other, if you want, sort of developing theory of cancer, which is the cancer stem cell theory. This is what we were talking about when they were looking at those breast tumors and saying that, 2 or 3% were stem cells. So the theory is that pretty much all cancers have their own stem cells. And these are the cells that are capable initiating, promoting, spreading the growth. While a lot of the other cells in the tumor are not so dangerous, they're growing, but they're not the ones that are in danger of spreading and killing you. The stem cells are the big concern here. And these are the ones, again, that usually aren't killed by chemo, radiation. They don't usually get the stem cells. So you can shrink a tumor, get it down into what looks like remission, but the stem cells are still hanging around, and that's why they keep relapsing. And then they were comparing that to Warburg, to the metabolic theory, which, again, these two new theories, and saying, well, maybe they're really the same thing. Maybe we're just getting two views of the same thing. That when you have the damaged mitochondria and these the changes that are taking place in the metabolism, the cells also become de-differentiated. They start becoming more like stem cells. So the stem cells themselves may just be the initial damaged cells that they're seeing with the mitochondrial damage. So what led from this is that, so how do we deal with the cancer? So if cancer has a unique metabolism that's different from the normal cells, can we make use of that? So here we're looking at just the use of carbohydrate restriction. It said because the cancer is using glycolysis, again, an inefficient method, it needs much higher amounts of glucose, usually at least 20 times more, in order to get its energy needs met. So if it needs so much glucose, what happens if we reduce their food? So here we're looking at not only is the high glucose something that the food for the cancer, but cancer cells also have a lot of insulin receptors and IGF-1 receptors. And these are receptors. The insulin is probably going to be driven up when you're on a high carbohydrate diet. When you drop the carbohydrates, you not only lower the food itself, but you lower the insulin response. So you're lowering one of the signals that's stimulating the growth of the cancer. So we're affecting it at least in two different ways here. A third way that it seems to be affecting it is that when you drop your carbohydrates, your body will start breaking fats down into ketones. They have the ketogenic diet. Ketones is a really good food for most of our cells in the body. But ketones are used in the mitochondria, which are not working normally in the cancer, so they can't make so much use of it. So now, by going on the low carbohydrate diet, you're not only reducing the glucose for the cancer, you're replacing it with something they can't use. In fact, they found that ketones themselves, even if you didn't change the carbohydrate, the glucose levels in the blood, just increasing ketone levels, which you can do actually even by taking supplements of it, will have an inhibiting effect on the cancer growth. And so this whole ketogenic diet for cancer was looking, very promising, and there's already a number of clinical trials that have started using it, mostly in combination with conventional treatments to improve results. And the other thing looking at it too, aside from reducing the food supply, the glucose, because cancer is primarily using glycolysis. In fact, the enzymes in glycolysis are generally turned way up in the cancer cells because they depend on this. And there are a lot of substances that can interfere with the enzymes that the cancer is using. In general, they don't have too much negative effect on our normal cells because they're not really using glycolysis very much. They're using the mitochondria. So one of the ones that they were looking at for a number of years was dichloroacetate, or DCA. one of the universities in Canada started doing a lot of work with this. And DCA was already on the market. It was already a drug that was being used for a metabolic disease in children. So this was a substance that was already available. They found that it inhibits some enzymes, especially one called pyruvate dehydrogenase kinases, with reactivation of another enzyme that's involved in mitochondrial function. So one of the ways they thought it was working is that it was reducing glycolysis but pushing activation of the mitochondria. And they thought this was working in a couple of different ways too. Again, one, it was inhibiting the normal energy production of the cancer, but if you're able to activate the mitochondria are also largely responsible for apoptosis, for normal cell death. So apoptosis, again, is turned off in cancer cells. So part of the theory is that if we can turn it back on, we may be able to get the normal death signals to the cancer restarted. And there was some indication that it was happening. And they did their preclinical animal studies. They even went to some small clinical trials, showing that there was benefit. Right after the small clinical trials, the researchers started getting frustrated because there was no more funding. The funding to continue further was stopped. Here's another one that was also, it's been in the news a lot in the last several years, something called 3-bromopyruvate. This was actually deliberately developed at Johns Hopkins, looking for things to inhibit cancer metabolism. So this one, they were specifically looking to develop something, and they found this molecule, 3-bromopyruvate, again, similar to pyruvate, which is part of the normal glycolysis patterns. One of the ways they think it's working is that they found in cancer cells, one of the glycolysis enzymes called hexokinase 2 is dramatically turned up, to assist the cancer metabolism. And bromopyruvate seemed to be a very powerful blocker of it. And it looks like when they continued research farther, that wasn't the only thing. It was working on possibly some other enzymes too. So they did a study of 19 rodents with implanted, with advanced cancers. And they gave them the 3-bromopyruvate, and they said 100% of them were cured. Not only did they say 100% were cured, when they stopped the treatment, it seemed the cancer didn't come back again. There was no relapse. And there were a couple of case studies reported. One was with a teenage boy with terminal liver cancer. At this point, he had 95% of his liver replaced by cancer. And they treated him by actually giving the bromopyruvate directly into the hepatic artery, putting it right into the liver. And it looked like it all disappeared. So it looked like all the liver cancer disappeared. The problem is that he didn't have much liver. Unfortunately, what happened to him after that is he got a bit of a respiratory infection after he went on a tour of the US to talk about the treatment. He picked up a respiratory infection. They put him on an antibiotic that affects the liver and apparently wiped out what was left. So he actually didn't die of his cancer, he died of no liver. But it seems similar to the DCA story that there's difficulty doing continued research with this, just in terms of funding. Another interesting substance, something called methylglyoxal. So methylglyoxal is something that we produce in our bodies. It's a normal byproduct of metabolism. The place where we find it naturally occurring in fairly high amounts is in Manuka honey. Manuka honey has become a popular supplement. And even before that, in the medical world, they were looking at it as a treatment for wound infections. And when they studied Manuka honey, they said, well, why is Manuka honey so good? And what they found was high levels of this substance, methylglyoxal, that seemed to be quite a good antibiotic. But they also found that it was inhibiting at least one of the glycolysis enzymes, glyceraldehyde 3-phosphate dehydrogenase. Interesting, it was also interfering in the mitochondria with something called mitochondrial complex 1. So part of the mitochondrial metabolism was also being interfered with by the substance, but not in normal cells, not in normal mitochondria. So this was just some other evidence saying that the mitochondria in a cancer cell is not functioning normally. So because this, I guess, substance was only affecting the mitochondrial ones. It's not that the mitochondria are gone, but they're not working right. Initially, there were some in vitro studies where they were showing some glycation toxicity when they were just testing it in a dish, meaning like when you have glucose binding to proteins they cause damage. They said this looked like it was doing some of that. When they studied it in animals and in humans, they didn't see it though. They didn't see really any toxicity. A group in India actually did a study. They did what they call a 3-phase human study of cancer patients. A lot of them were with cancer patients with advanced cancer. And they showed that most of them improved with the treatment. In fact, I think in their numbers they claimed about 40% of them went into complete remission. And this is with advanced cancers. And even the ones that didn't show any benefit in terms of the cancer, they still seem to feel better. And again, when they did the studies in humans, though, they didn't see toxic effects. Melatonin. Melatonin, interesting, was studied in Italy by the oncologists there. And they've combined it usually with standard treatments, and they're showing that they were improving results. And they found a number of different mechanisms how it was working. But this is something from just 2016, just a laboratory study. It looks like not only was the melatonin working by some other processes, it was also interfering with the cancer metabolism. So we're seeing, even with this other, if you want even more established, cancer treatment, in addition to other things it was doing, it was also getting at the cancer metabolism. And there was just a review paper of melatonin being used with chemotherapy, radiation therapy. It's a meta-analysis of a number of trials. And here they're showing that just melatonin, adding it to your treatment, approximately doubled the complete and partial remissions. And not only that, but it also seemed to have a pretty dramatic protection of the healthy tissues. So there was less thrombocytopenia, neurotoxicity, fatigue. So a lot of the damage from the chemo was also reduced with it. So we have melatonin, again, as another substance that seems to be in different ways improving cancer treatment and also probably disrupting cancer metabolism. This was an actual clinical trial done in France a few years ago. So this was a group in France that's been looking at this whole metabolic approach to cancer for a number of years now. So initially they identified 27 different compounds that can interfere with the cancer metabolism. Then they reduced it to 7 that they thought were working better. And then they started using 2 at a time. And they found a pair that looked like it was pretty effective in interfering with the cancer growth. Then they started a clinical trial. This was a clinical trial with 40 patients. In general, these were patients after all of their standard treatment. So they had all had their chemo, their radiation, whatever treatment they were doing. They were now considered terminal with 2 to 6 months to live. So this is the group that they took to put on their couple of supplements, to treat their cancer. And what they found was effective were 2 things. One was alpha-lipoic acid, which is a natural antioxidant that we produce in our bodies. And the other one was hydroxycitrate. Both of these have been on the market for many years now for other reasons. Hydroxycitrate actually comes from a fruit called Garcinia. And Garcinia has been on the market for a number of years now because people are using it to help them lose weight. And it may be doing it for the same reason that it's disrupting sort of sugar metabolism. They added one other thing to their treatment with something called low-dose naltrexone, which is another treatment, but it seemed to enhance the effectiveness here too. But I said these were the main two metabolic inhibitors that they put them on. And they had two groups. One group, they just gave these, and the other group, they added some other treatment like chemo to the protocol. What they found was that after 1 year, because they published after a year, because they expected no one to be alive at that point, according to their prognosis. But instead of no one alive, 60% of the ones only using the supplements were still alive, and 70% of the combined therapy. So which is pretty good compared to zero. And again, this is for something with essentially no side effects. There are a number of other things that are coming out that look like they could be disrupting cancer metabolism in different ways. They're still pretty early on in terms of research right now. One of them is very interesting, something called gallium maltolate. Gallium substances, for a number of years, have been looking at this as an anti-cancer treatment. One of the ways they think it works is that cancer doesn't just need a lot of glucose. It also needs a lot of iron for its own growth. And they found that gallium to a cancer looks a lot like iron. And it'll start taking up the gallium instead of iron, except it doesn't work. So it can actually stop the growth of cancer. It probably has some other metabolic disrupting effects in the cancer cells too. Very little in the way of any toxicity. And this is one that's actually can be taken orally. You know, it's like a 1-a-day oral treatment. There's a number of case reports with this one also. There's no clinical trial. Primarily because of no funding. But again, it's another one that's looking like another angle to be able to get at the cancer. Something else that's looking very good is fluorescein. Fluorescein is something that you can find in fairly high concentrations in apples, in the skins of the apple, and in the roots. Now, this is another interesting thing. It's on the market now, too, because they're using it for other things, especially for stuff like sugar for diabetes. What they found with fluorescein is that it does something different. Cancer, the other stuff we were talking about was affecting the metabolism inside the cancer cell. But the cell also has to get the glucose to use. And there are the GLUT receptors. There's the glucose transporters that are in the wall and the cell membranes of all our cells, but in very high amounts in cancer cells because they want a lot of glucose. And fluorescein looked like it could be a very potent blocker of at least two of the kinds of glucose transporters. So this way, we're reducing the amount of the glucose that can get into the cell. And then we have the other things to try to interfere with what does get in still. There's another thing that's been getting some attention too, something called salicinium, which is actually a glucose molecule bound to another molecule. And they found that this is also taken up into the cancer cells and seems to block glycolysis like a lot of the other things do. It was also doing something else which was interesting. They thought it was actually improving the susceptibility to the immune system, that when they gave this, it also interfered with the cancer being able to hide from the immune system. This is very early right now, so we're dealing with something that it's on the market, people can get it, but we still need a lot more work with it. Okay, so when we're looking at cancer, these are kind of what they call the accepted hallmarks of cancer. This is how cancer behaves. So they said, so cancer is cells that have self-sufficiency of growth signals. They can stimulate their own growth. They have insensitivity to inhibitory signals. They don't get turned off when other cells are telling them to stop. They're able to evade apoptosis. Again, they're turning off the normal death signals. And they can just keep going and going. They have chemicals to stimulate a blood supply so they can get the nutrients. And they have the ability to invade through tissue and to spread in the body. They're finding that all of these properties of cancer cells can also result from the mitochondrial damage. Okay, so when we're looking at the different qualities of cancer, what can we do about them? So when you look at the genetic damage and instability, there are natural compounds out there that can help protect the DNA from damage and from other mutations. They found hundreds or thousands of compounds in nature that can affect this. A lot of them being antioxidant vitamins like vitamin E and C, minerals like selenium and zinc, other bioflavonoids, things like curcumin, EGCG, which is the green tea, resveratrol, and other naturals produce things like alpha-lipoic acid and N-acetylcysteine. So these are all things that you can put in to try to reduce that particular aspect of cancer. The abnormal expression of genes, again, these oncogenes, these genes that are turned on in cancer, can you affect those? And there's also cancer suppressor genes. So you have genes to stimulate growth and genes to reduce growth. So how do we try to tune them so that we're reducing the cancer properties? So they found another number of natural things that can affect the gene expression. So these include things like vitamin C, vitamin E, melatonin, vitamin D, curcumin, EGCG, genistein, which is a soy derivative, resveratrol, selenium, quercetin. So these are the ones that are identified that we can get at this. Signal transduction. So chemicals that are signaling the cells that regulate the growth, how can we change the messages that are going to the cells? Here again, they found another naturally occurring things like boswellia, curcumin, the omega-3 fatty acids, other flavonoids, garlic, melatonin, some other plant-derived products like parthenolide, resveratrol, vitamin E. So we have a number of compounds that, again, have been identified to affect how the signals are being communicated. Cell-to-cell communication. So this ability of cancer cells to not listen to their surrounding tissues. So when they have, again, the cells around them are sending signals that's saying, okay, stop. Again, the cancer cells don't listen to it. They don't get the message. So are there ways to try to push the message through better? Here, they found a number of things. Vitamin A, genistein, which is the soy one, EGCG, melatonin, resveratrol, selenium, vitamin D. So again, a number of these natural occurring things that will affect that aspect. The ability of the cancer to move, to spread in the body. So cancer cells also have to make enzymes. They have to break down collagen to be able to move through tissues. They have to be able to get into blood vessels. They have to be, there's a lot of mechanisms that go into a cancer cell being able to spread in the tissue and in the body. So some of these enzymes like collagenase, hyaluronidase, heparinase, these are produced by the cancer. And there's things that can help reduce it. Boswellia, gotu-kola, these are the proanthocyanidins, resveratrol, vitamin C, A, curcumin, EGCG, EPA, and other things specifically to affect the migration of the cells, vitamin D, omega-3s, genistein, melatonin, ginseng. You may be noticing that in a lot of these slides, we're seeing a lot of things appearing repeatedly. So we're seeing how, again, a lot of the same substance will go after many different aspects of the cancer. Immune surveillance, again, the ability of the cancer to hide from the immune system. Can we get the immune system to find them better? This is actually a big area of research right now in immunotherapies. How can we rev up the immune system to see if we can get it to go after the cancer? A lot of promising things that are being developed. So far, not too many of them are giving us dramatic results, but it's a direction. But there are already a number of natural things to help with that. A lot of the mushrooms, things like shiitake, maitake, some other mushrooms, are helping with the immune system function. minerals like zinc and selenium, glutathione, vitamin C, melatonin, certain enzymes, especially bromelain and pancreatic enzymes. They found that a lot of the proteolytic enzymes that we produce also help the immune system be able to find cancer. Maybe because it's breaking down some of their protective coatings. And the other aspect to try to get at the cancer is with blood sugar and insulin regulation. So here's where we come into the ketogenic diet, reducing the food supply. So we want the low carbohydrate diet, and there's other things that help with blood sugar regulation. Vitamin D, berberine is looking really promising. In fact, it's a diabetes treatment. Cinnamon, chromium, certain berries like coffee berry, plants like herbs like holy basil. So these are all things that have their own modification of glucose regulation. And if we look at just trying to put all this together, this is just an example. We have to customize, our treatments to different patients. But we want to include a lot of these things. The fat-soluble vitamins are also all important anti-cancer nutrients. Vitamin D, vitamin A, another one, K2, seems to be part of this fat-soluble team that has very good anti-cancer effects. Vitamin E, and maybe especially parts of vitamin E that we don't pay as much attention to, like the tocotrienols. You may not know vitamin E is actually 8 different substances. They have 4 tocopherols and 4 tocotrienols. Most of the work with vitamin E has been done with alpha tocopherol, with one particular one. But we have all these other components of it that may have more important anti-cancer effects. So if we want to give vitamin E, we want to give the vitamin E complex, not just alpha tocopherol. Minerals, again, that we know have anti-cancer. We want to have a multi-mineral, especially getting good amounts of magnesium, zinc, and selenium. These are, again, some of the identified ones with anti-cancer mechanisms. Omega-3s, which can help reduce some of the inflammation and some of the cancer-promoting chemicals. Same thing with curcumin, green tea, resveratrol. Again, these natural substances that we've identified to reduce mechanisms of cancer growth. Some of these things we can get from our foods by improving food sources like nuts and seeds, and broccoli is a really good source of something called sulforaphane, which is an excellent anti-cancer substance. Seaweed, mushrooms. So we want to get all of these, more nutrient-dense foods into us. And then, of course, the whole metabolic, the ketogenic diet, even with supplements of ketones to try to raise it even further. And besides this, there's many other things that can be added to it. I probably have a list of about 200 different substances with identified anti-cancer effects. And then when we're doing the specific, going after the cancer metabolism, again, we want to do the ketogenic diet. They found that they can enhance the effect quite a bit if they add hyperbaric oxygen. So putting people in these tailakhats, in these tanks with compressed oxygen, also seems to be enhancing this anti-cancer effect. Like in the clinical trial, alpha-lipoic acid, hydroxycitrate, these are things that can be easily added to any program because they're easily available. Some of the more difficult ones to get are going to be things like DCA, bromopyruvate, methylglyoxal. So some of these other metabolism inhibitors, they're not so accessible right now. Melatonin is, of course. Creatine, they also just found it was a one to enhance, it has its own mild anti-cancer effect, but it seemed to enhance a lot of the methylglyoxal anti-cancer effect. And even adding a ketone supplement. Phenylbutyrate, I have on the list here. Phenylbutyrate is another thing that's naturally produced, maybe mostly by our microbiome, by our probiotic bacteria. But they found a number of anti-cancer effects of it. Another interesting one is that, unfortunately, cancer doesn't just use glucose. So even if we take away a lot of the glucose, it has some other second choices, things like glutamine. So the glutamine is a particular amino acid that can be metabolized very similar to glucose. And cancer cells are able to access that one too. They found phenylbutyrate, in addition to some other mechanisms, also binds glutamine to make it less available to the cancer too. So this way we're just trying to sort of cut off even some of the escape routes that the cancer may be able to use. So this is kind of our overall plan, is to modify or reverse as many cancer-promoting factors as possible, try to disrupt the cancer metabolism, try to do many of the things at the same time. And again, for this, you usually need to utilize combinations of things. Again, like almost all the studies showed, single things, even if they have some effect, they're not going to have nearly the effect of using combinations. And the other thing in terms of the program is not just to go after the cancer, but also to protect the body. Most of these people are going to be getting chemotherapy, radiation, the conventional treatments, which are really toxic. They can cause a lot of nerve damage, liver damage, a lot of organ damage, and a lot of that can be reduced dramatically when we add some of these protective substances. So we want to be able to go after the cancer, but we also don't want their conventional treatments to kill them. Just one case report to finish with. So this is a 3-year-old girl with high-risk neuroblastoma. So neuroblastoma is a very deadly childhood cancer. Most papers, if you start looking at neuroblastoma, they almost all start with childhood cancer with a dismal prognosis. So this one, showed at the beginning there was diffuse cancer right from head to toe. And there are a few children who do show some long-term survival with aggressive treatments. Not very many, there's a few. But even if they do, they usually have a lot of damage. There's a lot of organ damage resulting. And not only that, but even if you survive the first cancer, there's also a high risk of developing a second cancer because of the cytotoxic treatments. So it's a bad thing. So she was treated with the standard aggressive therapy and started right at the beginning on intravenous vitamin C and multiple supplements. After 3 months, they did a repeat of the scan, which didn't show tumor. So the head-to-toe tumor was cleared. The intravenous vitamin C was continued for even a year after things looked cleared. And now, she's still alive, healthy, no heart nerve damage. So she's come through it as an exception. Again, a very exceptional case, both in terms of surviving and in terms of the lack of most of the organ damage. But this was, again, one that was started with the conventional treatments and with really aggressive, both intravenous and oral nutrient therapy. I mean, there's other case studies we can show. This was just an example of at least the potential. So this one I know well because it's my daughter. Okay.
Thank you so much. Questions? So the list that you gave of substances, these are for cancer treatment, but
Cancer treatment, cancer support.
same doses you would use for prevention?
Pretty much. No, usually you can do less, I mean, for prevention, but the doses I'm giving there are not, they're not mega doses. Except for intravenous vitamin C. These are doses that were probably normal in our food supply 100 years ago. It's just that our food supply now has dropped so dramatically in most of these nutrients that we're now calling them megadoses. But again, this is not what would have been considered, huge doses of anything. I mean, vitamin D, I'm talking about giving 5,000 units of vitamin D. One way to look at, is this a really high dose, is to look at what used to be normal. So vitamin D, we used to make in our skin when we got out in the sun. And we used to have to walk in the sun, work in the sun. Nobody invented sunscreens. So we were getting a fair bit of vitamin D. If you're in the sun, especially in the summer, in the middle of the day, within about 20, 25 minutes, you can make about 15,000 units. So we're designed to be making a lot of vitamin D naturally in our body. No one got overdosed by working in the sun. So we're designed to have good levels of these things. It's just that, again, with our modern lifestyle now, instead of 15,000 units in a day, to make vitamin D, maybe we're making 200, if we're lucky. Actually, I had some blood levels of some women who actually came back with undetectable. They were so protected from the sun that they couldn't detect vitamin D in their blood test. And that's a dangerous situation. So again, when you're talking about these doses, I said 5,000 units is less than what we used to make naturally. Magnesium, another really important mineral, zinc. Again, these are really important anti-cancer minerals. When they looked at a lot of the food supply now, they find that they could be down about 80% compared to the same food in the past. So our ability, to get the... so again, when I'm looking at the doses of these kind of minerals, this is what we were probably easily getting in the past. And are now called, megadose therapy. So these days, food comes in little capsules. That's how we compensate. Or you get your own farm. And you raise your own organic food. Oh, but by the way, that's even another way that we've been getting more depleted. One of the things they found with some of the pesticides, some of the stuff we're spraying on all the food, not only can they be toxic in themselves, but some of them are actually binding minerals and not making them available. So what little minerals may be left in the food, we're not getting because now we're binding them to other chemicals. Yeah, so like I said, when I'm looking at this nutrient program, I'm looking at just how do we make up for what we messed up.
Maybe you can elaborate more about the ketogenic diet that you mentioned.
Okay, the ketogenic diet, are people familiar with it? Or? The paleo is close, it's not exactly. The ketogenic diet is a very low carbohydrate diet. You get your carbohydrates down around 10-15% of your calories. Once you get down that low, your body will start breaking down fats into ketones to replace the glucose as an energy source. And again, our normal cells are very happy with it. They'll use ketones. It probably is a more efficient source than even the glucose is. But they said the cancer cells can't make use of it. In fact, the ketones themselves may be inhibiting the cancer in some ways. There are many different ketogenic diets around. The original one was actually started for treating seizures in children about 100 years ago. Because they also found that when they reduced the carbohydrates and increased ketones, it was stopping seizures. It was having some really good brain effects. And then there was the Atkins diet, which came out a number of years ago. Mostly he was using it for weight loss. And again, it was a very low carbohydrate diet, but it was also a very high protein diet. It was very high in meats. The diet we use for cancer, we don't want so high in the meats. Also because we don't want such a big supply of things like glutamine which may be a substitute source. So for cancer specifically, we want to have the same low carbohydrates, but we actually want to have the fats to be much higher and not really to increase the proteins. So this means getting a lot more oils from olive oil, coconut oil, sesame oils, butter, even animal fats. Animal fats are actually quite healthy as long as they're not poisoned. So if they're not full of antibiotics, pesticides, etc. Right. But the fats themselves are actually quite healthy. And again, these are things that are not available to the cancer. They found certain fats that you get in things like grass-fed beef, not the regular, that are very high in something called CLA, which is a fat that seems to have some very powerful anti-cancer effects itself, aside from just being something to provide ketones. So we want to increase nuts and seeds are another good way to increase the oil content. So these are the foods that we want to try to fatty fish. These are the ones that we want to try to build up in the diet to try to, again, increase the good oils and bring down the carbohydrates and, again, make life much more miserable for the cancer. There are some websites now that will give you the details. Some of them will even give you recipes on how to make the food, even videos on how you can prepare your food according to a ketogenic diet. So it's out there. It's becoming much better known. It's also a treatment for diabetes. I mean, it's probably the ideal treatment for diabetes. You're bringing down your sugar, you're bringing down your insulin levels. I mean, this is... But in terms of cancer, I said we more specifically want that, again, low carb, high good fat.